Hi, this is Joe Shaker. I know many of you. I'm an endocrinologist at MCW. I'm really happy to introduce Peter Tebben. I've been trying to get Dr. Tebben to give this talk about hypophosphatemia at the Bone Club, but then he just moved to Yale. So, as a little background, I've known Peter for many years. He's med peds endocrinologist. He's been at Mayo Clinic for many years, has great expertise in osteoporosis, metabolic bone diseases, calcium and phosphate problems, and in particularly rare bone diseases. Has a lot of publications, is an excellent teacher and clinician, and just recently, in the past month or so, moved to Connecticut at Yale to be the head of the bone program in their endocrine division. And he's really lucky to be there because he has, as he said, two and a half grandchildren in Boston. And so Peter, I'm very happy for you. We miss you here, but I'm very happy for you and your family that you're close to your grandkids. And I really appreciate you doing this. Thanks.
Absolutely. Thank you, Joe. Thank you for the very kind introduction and invitation to speak tonight. And I had the opportunity for the first time to go to the Wisconsin Bone Club's spring meeting earlier this year. It was outstanding, and certainly regret that I had not made it to the meeting in years past, but hope to make it back to the Midwest to get to more of these in the future. So as you heard, we're going to talk a bit about hypophosphatemia this evening. See if I can make sure. There we go. So as far as disclosures go, have some research funding. We're not going to talk about anything that's off-label, though. Over the next 15, probably closer to 20 minutes, the three things I really want to cover is just talk a little bit about understanding phosphate homeostasis. I recognize this is not something we all think about every day. So just getting back to the basics a little bit to understand what are the factors that influence phosphate homeostasis can really help us in our approach then to evaluating the patient, and ultimately coming up with a diagnosis, and then understanding our treatment options for patients with chronic conditions associated with hypophosphatemia. So that third part, we're really going to focus on the FGF23 or fibroblast growth factor 23 mediated causes of hypophosphatemia, because as you'll see, a lot of the other causes of hypophosphatemia are self-limited, or once you identify the underlying cause and treat that, the hypophosphatemia resolves, but that's generally not true with the FGF23 conditions. All right. So phosphate homeostasis. So when we do a blood test and measure a serum phosphate concentration, what are we measuring? Really, we're just measuring what's here in this extracellular pool. But there are quite a few things that contribute to that extracellular pool. Of course, what we eat, our food, is replete in phosphate. It's almost difficult to have a low phosphate intake diet. But anything that we eat, or if we were on a supplement that contained phosphate, that is going to get absorbed through the GI system and contribute to the extracellular pool and what we measure in the blood. And then some of that's going to get excreted back into the GI tract and detract from that pool that we're measuring. And then over here on the other side, we have bone. And we typically think of bone as a major reservoir for calcium, which of course it is. But hydroxyapatite, the mineral that makes that bone or makes our bones hard, is both calcium and phosphate. So anything that promotes bone formation is going to take phosphate out of the extracellular pool. Anything that promotes bone resorption is going to put it back. But really where the fine tuning of phosphate homeostasis comes into play is in the kidney. So we've got this filtered load of phosphorus that's going to go through the kidney. And when it hits that proximal tubule, we have these sodium phosphate transporters there. And the more of these that are present, the more phosphorus we can reabsorb back into the serum. And so if we have a relative deficiency of these transporters, then you're going to lose more phosphorus out into the urine. So this is really how our serum phosphate concentrations are in large part, how it's regulated so tightly is through these sodium phosphate transporters. So what influences the system? We've got parathyroid hormone. And again, we think of parathyroid hormone as primarily regulating calcium metabolism. It also influences vitamin D metabolism. But PTH is a key regulator of phosphate homeostasis as well. And one of the ways it does that is through these sodium phosphate transporters. So when our parathyroid hormone concentration goes up, then we actually have a downregulation of these transporters, so we lose more phosphorus in the urine. So high parathyroid hormone in the blood means more phosphorus escaping the system out into the urine. Parathyroid hormone increases active vitamin D production and also promotes bone resorption. So a couple of secondary ways that it can influence phosphate homeostasis. On the other side, we've got FGF23, or this fibroblast growth factor 23, that is a phosphate regulating hormone. Under normal conditions, it's made in the bone, circulates to the kidney, and just like parathyroid hormone, if you have excess FGF23, you lose these sodium phosphate transporters. They get downregulated, and when you don't have enough of those, then you lose phosphorus through the kidneys, and it goes out in the urine. In contrast to parathyroid hormone, if you have excess FGF23, it actually shuts off active vitamin D production, so our calcitriol levels go down. So that difference in how these two hormones affect vitamin D really is going to help us out in a bit when we get to another slide that shows, well, how do we interpret, or what kind of algorithm can we use to interpret our laboratory tests to get come to a diagnosis for a patient that we might be seeing in clinic that has hypophosphatemia. All right. So if you open up a textbook and look at the long list of things that can cause hypophosphatemia, it is kind of long, and I find that daunting. So I try and keep things as simple as I can, just to organize it in my head. And so we can really break this down into three different categories. There's really just three options for what might be causing hypophosphatemia. Either you don't have enough coming into the system, or maybe it's moving around, it's in the body, but it's just getting shifted into different compartments, it's being redistributed, or we've got too much out. And we're going to end up focusing mostly on that too much out category, because that's where those FGF23 problems show up. So what fits into this not enough in category? Well, if you really have a very low phosphate intake through your diet, that's not very common, but maybe the patient who's on chronic TPN, it can be really hard to provide enough phosphate through TPN to maintain the body's needs. Or if there's a malabsorption syndrome, short bowel syndrome, you're just not absorbing probably many nutrients, not just phosphate, that might be another reason. Or if we get overzealous with our phosphate binders. And you'll see through the talk, I've got this guy holding the key, just some key bits of information I think that hopefully will be helpful in your practice when you encounter some of these patients. But how do we know this is the category a patient is in? Well, if you don't have enough phosphorus going in and our kidneys are working properly, you really shouldn't be excreting any or very little phosphorus in the urine. So if you measure their urine phosphorus and it's very low or undetectable, this is probably the group or probably the category that your patient is in. In addition to that, calcitriol or active vitamin D tends to go up quite a bit in the face of hypophosphatemia. So in the absence of some other condition leading to hypophosphatemia, this group will see low urine phosphorus and high 125D levels. Redistribution, this one doesn't take any fancy tests to make a diagnosis. Really, this is going to be an acute or subacute onset, and clinical history is going to tell us the answer. And you've probably all seen them. If you've seen a patient with DKA, we all think about the hypokalemia that occurs after starting insulin therapy. Well, the same thing is happening with phosphorus. You start that insulin therapy and it's pushing the phosphorus intracellularly so that serum phosphorus can drop. Hungry bone syndrome is that mineral is being taken up after parathyroid surgery for somebody with typically more severe or long-standing primary hyperparathyroidism. So again, usually don't need a big workup here. Just a good history is going to tell us if we're in this category. And then the too much out category, this one also has quite a few conditions that live in it. So I break this one down a bit more too. So parathyroid hormone mediated are patients with primary hyperparathyroidism or secondary hyperparathyroidism often will have low or at least low normal parathyroid hormone concentrations. Remember, anything that causes that PTH to go up, it's going to cause us to lose those sodium phosphate transporters in the kidney. So we're just peeing out more of that phosphorus. And then this next category, this FGF23 mediated, this is where we're going to spend some more time in a few minutes talking about treatment of these conditions. But by far the most common one from a genetic perspective is this X-linked hypophosphatemic rickets. Maybe 1 in 20,000 people in the population have that. I suspect that most here tonight are C adults in this tumor-induced osteomalacia. While it's rare, it's a condition we really don't want to miss because it causes so much morbidity, pain, fractures, loss of mobility, and we can have a dramatic impact on quality of life for these patients if we simply think about it, try and make the diagnosis, and come up with a treatment plan. I put a star by this third one, some iron infusions, iron carboxymaltose in particular. It has been shown to increase these FGF23 levels, which can lead to low phosphorus. And sometimes that can persist long enough after an iron infusion that they become symptomatic. So always ask about recent iron infusions, since this can lead to sometimes months-long hypophosphatemia. And if we think to ask about it, maybe we can avoid a big laboratory and imaging evaluation that's just not necessary if we just need to wait it out because it was due to an iron infusion. And then this last category is a smaller group. These are really those intrinsic problems to the renal tubule, renal Fanconi syndrome, where that proximal tubule just isn't working to reabsorb many things, including phosphorus. Or if there's a mutation in those sodium phosphate transporters themselves, that's going to lead to low serum phosphorus just because you can't reabsorb that phosphorus efficiently. So we've talked a lot about this urine phosphorus and too much out. Well, how do we even assess that? Probably the easiest way clinically is to calculate a tubular reabsorption of phosphorus. And it doesn't take fancy tests to do it. We just need blood and urine phosphorus, blood and urine creatinine, measured at the same time. But how we do that is key. We want to measure it on a fasting sample. And ideally, that urine sample would be a second morning void. Sounds complicated, but it's actually easy. You just have your patient get up in the morning, empty their bladder into the toilet, flush it down, and tell them drink a couple of glasses of water on their way into the lab. And by that time, they can probably produce a little bit more urine, have their blood test done. Then we can use that information to calculate this. And if your blood phosphorus is low, we should be reabsorbing, holding on to almost all of that phosphorus. So we should be reabsorbing at least 95%. So if it's less than that, we're probably in this category of too much out, leaking phosphorus through the urine. So this is an algorithm I found helpful. Others have published other algorithms, but I'm just going to go through this with you to see how this could work. So, of course, we always take a detailed history, and we're going to find those redistribution patients, the post-parathyroid surgery or DKA patients here. And then I like to look next at that urine phosphorus because it figures out those other two buckets, that not enough in, which is going to lead to a low urine phosphorus, or too much out, which then I divide up into parathyroid mediated or not. And if we're in this normal PTH category, this is one of those instances where measuring an active vitamin D and also looking at a urine calcium can be helpful, because if those are high, it's probably not FGF23 mediated, because remember, that pushes our active vitamin D level down. So if that active vitamin D level is either low or low normal, that's inappropriate in the context of a low serum phosphorus. So we're probably in this FGF23 mediated category. And notice I haven't included that we measured an FGF23. It's easier to find labs to measure that for us now compared to 10 or 15 years ago, but it's not available in all labs. So that's why I kind of like this algorithm, because even without having to find out where do I measure that, how do I do that, we can generally fit a patient into one of these categories with pretty basic laboratory tests we should all have available to us. So that's, I know it's pretty quick, but sort of my approach to thinking about how do we come up with a diagnosis, or at least which category are these patients fitting into. And so then if we think about patients with FGF23 mediated disease, we've got a few different treatment options there. And what are the two big, most common diseases I'm thinking of? The X-linked hypophosphatemic rickets patients. Again, about 1 in 20,000 people will have that, by far the most common genetic cause. And so if we're seeing that run in the family, this is most likely what we're dealing with. And then the patient with tumor-induced osteomalacia would fit into this category as well. There are a variety of other genetic conditions that can cause it. They're just much less common. Our treatment options are to replace the phosphorus and calcitriol that they're deficient in, or since 2018, we've had burosumab, or this anti-FGF23, so we can block the effect of that hormone that's too high. Or for the patients with tumor-induced osteomalacia, we can send them off for surgery if we can find it. For the adults that we see, not all adults with XLH need to be on treatment, but some do. And certainly if they have musculoskeletal symptoms that we think are related to their osteomalacia, they're going to have an orthopedic procedure. If they've had fractures or pseudofractures, these would all be reasons why we'd recommend having them on treatments. In the past, when all we had was phosphorus and calcitriol, our goal was really to address these three issues: their symptoms, appropriate healing after surgery, heal fractures if they had them. But it wasn't necessarily to normalize their serum phosphorus, because we can overdo it with conventional treatment. If we get the doses too high, we might cause more harm than good. And this is in contrast to the burosumab therapy we'll talk about in a minute, where our goal really is to try and normalize that serum phosphorus level. But with conventional treatment, the goal is to get the right balance of these two. This is a high-intensity treatment. Takes taking the medication 2 to 5 times per day, lots of monitoring to make sure we get the doses right and we don't get out of balance. If we get out of balance, either direction, we can end up with some of these potential side effects, and some of which can have long-term consequences, including chronic kidney
Hello?
disease. Yes?
Hello?
As far as, so
Hello?
that's conventional therapy. And at the end, you'll see I've got some references in there. So anybody that wants more detail than we can go into tonight can reference those. Since 2018, as I mentioned, we have more targeted therapy, though. So we can actually block the action of that excess FGF23 with burosumab. This is approved for patients with XLH and those with tumor-induced osteomalacia where we can't find that tumor. Lots of studies have been published. We're certainly not going to go through all of them. Just a couple of slides. I show this one because it's a head-to-head trial with our old conventional therapy. This one happens to be in kids. And this is looking at how severe the rickets is on an X-ray. So the lower the number, the lower the severity. And you can see with the lighter blue bars that the burosumab group improved those rickets, the rickets to a greater degree than those who stayed on conventional therapy. So two takeaways I have from this study. One is burosumab seems to work better than conventional therapy, but there is still some rickets. 0 is perfectly normal X-ray, so they didn't perfectly normalize. So there is residual disease. This is a study looking at adults and looking at fracture healing with burosumab for 24 weeks, burosumab versus placebo, and then everybody got treatment. I think the same story. Treatment is better than no treatment. That's not a surprise. But even out to nearly a year, not everybody had full healing of their fractures. So while this is a good therapy, it's not a perfect therapy. So it sort of brings us to, well, what's sort of the next step with targeted treatment for these conditions? And I think the next step really is this burosumab 2.0. This is a newer version, same company. They're trying to address a couple of issues. One is trying to make it more concentrated so that they can give all of the dose in a single injection instead of multiple, and also increase the duration of action so it doesn't seem to wear off so quickly. For some adults in particular, it seems to wear off before that next dose is due. So last part, I just want to finish up with this tumor-induced osteomalacia. Just like real estate, location is what it's all about. trying to find where that tumor is. They can be anywhere from head to toe. So a detailed physical exam, functional whole body imaging. The reason for that is because these tumors can be anywhere in the body. So we want a picture that that sees everything. And if you have access to it, this gallium-68 dotatate scan is probably the best that we have, although none of these are perfect. None of them are going to identify all tumors. And then we follow up that with anatomic imaging, usually CT or MRI. Venous sampling probably doesn't have a big role in locating these tumors. So our treatment options for TIO are a bit different than the XLH. XLH we can't fix because we don't have gene editing, at least not yet. So surgery, if we can find the tumor, surgery is really the treatment of choice, because if we can take that tumor out entirely, we can cure the disease. It is important to know that these can recur locally. Occasionally, they can be metastatic and malignant. Fortunately, that's the exception. But if it's in a location where a wide local excision is possible, that's really the best way to go to minimize that risk of recurrence. If you just try and take out the tumor and don't take out much around it, it's more likely it's going to come back. But if surgery is not an option, we still have medical management options, phosphate and calcitriol, or that targeted treatment with the burosumab therapy. So I know that was a bit of a whirlwind. Hopefully we've got some time for discussion and questions, but takeaway points, number one, just remember to measure serum phosphorus. And anyone who has unexplained musculoskeletal symptoms, some of these patients go years before getting a diagnosis. History and some relatively basic labs can help us establish a diagnosis. A high urine phosphorus and low or inappropriately normal calcitriol level really points us towards that FGF23 mediated process. And then treatments for FGF23 related disease, surgery for TIO, if we can do it, that's always our goal. But if not, we do have other good treatment options, including conventional therapy with calcitriol and phosphorus or targeted treatment with burosumab. I'll leave this up just for a second, just so it'll make it into the record and can see it online later if you want to reference these for more details on any of these conditions in the future. Appreciate your attention and happy to answer any questions.
So Peter, while people are getting ready with questions, I'll ask. I have two that are. One is, are you in adults? Are you using the every 2 weeks at all? And splitting the dose?
Yeah, I have. It's challenging though, because once patients turn 18, some insurance companies don't allow that. And because it's fairly regulated, it's through the Kyowa Kirin Cares program, they send a nurse out. It's hard to organize that sometimes where they can do a split dose unless the patient's willing to self-inject, which a lot of them end up doing. But I have switched some adolescents that were done growing, changed them to every 4 weeks from every 2 weeks, and they didn't do well at all, and did revert them back to every 2-week dosing.
And in adults, what is it's 1 milligram per kilogram is the
Starting.
starting. What's the top?
The top is 2 milligram per kilogram per dose.
Up to
But the
like 90.
maximum, you max out at 90 milligrams.
Yes,
So.
okay. That's what I thought. Okay.
Yeah, so those are hopefully with this newer version that they're looking into, it's going to be, I'm sure, years before we'd have access to it. But I'm glad they're trying to improve on what they have. Really should address, or hopefully addresses, that issue of duration of action. So maybe it won't be wearing off as soon and won't have to inject quite as often.
So the other question is, I have a patient with TIO. I've been following him for 20 something years. We have not been able to find it. I sent him to NIH. He's had genetic testing. They've looked for everything. We've all done a bunch. We can't find anything.
Yeah.
And he's on burosumab, but he does have hyperpara. And it seems like that's making it hard to control. And I wonder if I should send him to parathyroid surgery, and then it might be easier to manage. Do you have any experience with the patients that have both?
Yeah, if they're, I've seen patients develop tertiary hyperpara because of sort of overzealous phosphate supplementation, and they did benefit from surgery. I think Dr. Alon from Kansas City had done some studies a number of years ago using cinacalcet to try and lower PTH values, which then can help bring those phosphate levels up. So if they have primary or tertiary hyperparasurgery might be a good option. Maybe better than long-term cinacalcet, but
He's
that
on
would be a little bit.
cinecalcid, yeah.
Yeah, all right. Well,
Okay, I
maybe
forgot to say.
surgery is the right
My
next
bad, I
step.
forgot to say that.
Yeah, because
Okay,
anything that's causing the PTH to be higher is just going to make it harder
harder.
to keep the serum phosphorus in a reasonable range.
Okay, other questions? I'm looking in the chat. I don't see any, but if anyone wants to, or am I not looking at? I can't
Oh,
tell. Diane, is
Elaine,
anyone's
Hi,
hands
this
up?
this is Elaine. Hi.
Hi, Lane.
I have a handful of people on Burosumab for XLH. I have a family that I follow. And at least two of my patients are on max doses and their FOS is better, but it does not correct. They're happy, they feel better, they don't want to stop it. But how many of your patients have you put on and gotten up to the 90, which at least in both of them, I think is pretty close to their weight-based dosing, but we've maxed it out, and their FOS doesn't correct.
Yeah, I think that definitely happens. I don't know what percentage that occurs, but of the adult patients that I have, I'd say at least half of them are on max dose. Most of them have phosphorus levels that generally live in that lower half of the normal range. But I do have two or three that 2.2, 2.3, 2.4, sort of where they live,
Mhm.
almost regardless of when during the cycle I measure their phosphorus level. But in large part, they're doing fine. Their alk phos is fine. They're not fracturing, no bone pain. And so, okay, if my treatment goal is just the blood level, we're not hitting it. But if my treatment goal is to improve their symptoms and eliminate symptoms of osteomalacia, then we've achieved the goal. And so I've been happy, content to say, okay, fine, your serum phosphorus is a little bit low. You're clinically doing wonderfully, so we really don't need to probably worry about it too much. And again,
Yeah.
maybe a newer version of this will help us do a little bit better.
Yeah, that's kind of the tack I've taken. I think so. Oh, at least one of them, they're sitting closer to two. I mean, it's not even
Yeah,
like it's definitely low,
yeah,
consistently. But symptomatically they feel better, and so even they want to continue. I got pushback from a payer because they looked at records and said this isn't working. And I
yeah,
had to remind them exactly that the number is not the primary target of therapy. And so far we've won
right.
the battle, but it's been interesting that I've had two clear-cut cases that I max doses are not normalizing their FOS.
Yeah.
So there's a couple questions in the chat, Peter. Chris Morganti is an orthopedist at Madison, and she's asking, can hypophosphatemia be associated with low creatinine related to an enzyme deficiency?
Hmm. Not, not that I'm aware of. I have not seen that clinically. I don't think I've read about that either. I don't know, Joe, have you run into that?
No, I don't know anything. I don't know. I don't know. Not that I know of.
Yeah.
So the other question is about genetic testing for XLH is often required. Is it covered?
I had pretty good luck getting it covered, and for the longest time, when Ultragenics was running their clinical program to help people get set up with treatment and work on prior auth, you could get free genetic testing through them. I believe the same is true now that Kyowa Kirin has taken that over. So either measuring an FGF23 level or having genetic testing, those are sort of the two things I've run across mostly that insurance companies want. And if they're saying you have to have the genetic test to get covered for the drug, then generally they've paid for the genetic testing if we haven't found a free program to get it done through.
Yeah, I think that's true. I think if they ask you to do it, it'd be almost impossible for them to not pay for
Right,
it.
right. Be a bit of a catch-22 if they didn't pay for that.
If Peter, that was terrific, clear, helpful, beautiful lecture as usual. Thank you very much.
Thank
We
you.
really
Welcome.
appreciate it.